My name is Carol Postlethwaite and I'm an obstetric physician, and I'm going to talk to you today about managing women who are pregnant who appear with medical problems. Beep, 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 beep. Met call to the delivery suite. Or, hi, I'm the obstetric reg. Is it all right if I just have a chat to you about a really complex patient that I'm managing? Does this fill you with dread? Well, you're not alone. But don't worry, it doesn't have to be this way. Like most things, the more you learn about obstetric medicine, the more women you treat, the less scared you'll be. Once you understand the changing physiology, and treating women in pregnancy is really satisfying, and it's a fascinating specialty. Now, 20 minutes is not even enough to scratch the surface of obstetric medicine, so we're just going to talk about a couple of things to whet your appetite a little and to give you guidance on where to get help and resources to help in your everyday jobs and to answer questions from women. Now, if not managed correctly, women can and are damaged or die in pregnancy from acute and chronic medical conditions. The obstetric CPOD report is called the Embrace report, and right from the start it identified that not all obstetricians have good medical knowledge, and for the most part, most physicians don't know very much about pregnancy, in particular both what is normal and what is not normal, even at consultant level. We've worked hard with the RCP to ensure that medicine in pregnancy is included in the curriculum of all medical trainees as a result. You should expect exam questions in MRCP in all of the exams, even PACES, and in the higher IMT and specialty exams too. So what kills women, and is it important? Well, we look at two different sorts of deaths in the CPOD report. The first one is direct, which is where the death is directly due to a problem inherent to pregnancy, such as massive obstetric hemorrhage or puerperal sepsis. And then there's indirect deaths, and this is normally where we get involved, because the deaths are due to where a woman has come into the pregnancy with an acute or a chronic medical problem, and it's the interaction of that problem with the pregnancy that causes the death. Direct deaths have dropped significantly over the years due to the sterling work of our obstetric colleagues. However, indirect deaths have not. Why is this? More women are becoming pregnant at an older age and often with concurrent medical problems such as coronary heart disease or diabetes. Others with medical conditions such as transplant, pulmonary hypertension or congenital heart disease that only 10 or 20 years ago would have been dissuaded from having pregnancies now can be supported through pregnancy, but who do go in with much higher risks than others. It might not be an enormous surprise then that cardiac disease tops the chart for causes of death in pregnancies, but it's not all postpartum cardiomyopathy. It's coronary artery dissections, genetic channelopathies causing adult cardiac sudden death syndromes, and also ischemic heart disease presenting earlier in women. In the second group of thrombosis, PE is obviously there, but also venous sinus thrombosis. Neurological conditions come third, and those are mainly represented by sudden unexpected death caused by epilepsy, stroke and brain hemorrhage. Many cases present as headache, and please remember that all cases of headache should have a full neurological examination, including fundoscopy, before you consider imaging. Death after pregnancy, and we look at 6 weeks to a year after pregnancy, is very different, as you can see, and there's a lot of coincidental malignancy, but also it's more represented by psychiatric conditions such as suicide, drugs and alcohol, or even murder. Pregnancy takes its toll in very many different ways, and women are very, very vulnerable. We don't get it right all the time either, and about half the cases that have been studied showed that improvements of care could have occurred. And more to that point, 29% of cases, improvements would have changed the outcome. And remember, the outcome in this point is death. That means a child and a family that have lost their mother. Please read these reports. They're all available for free online, and they make for sobering reading if you read the vignettes. There are also useful pictographs that come at the end of each of these reports that summarise the year's finding. As you can see, the 2018 year looked at drugs and how they interact with pregnancy, both having drugs that are bad for pregnancy, of which there aren't very many, but more often not taking medications because the woman has unwisely or been told that drugs are unsafe in pregnancy. We also started to look at ethnic disparities in death, which were then looked in more deeply in 2019. And you can see here that there's a huge disparity between which ethnic group you belong to and how likely you are to die during pregnancy. But it's not just death we're looking at, it's also morbidity. So Jackie presented to a district general hospital with a headache. The obstetricians were particularly keen to exclude preeclampsia, but after they'd excluded preeclampsia, they didn't know what to do. More careful examination of her found a proptosis, more on one side than the other, with a loss of colour vision to that side. The MRI that you can see here identified a huge frontal tumour, and so she was delivered because she was at 35 weeks and sent up to King's, who removed her tumour, and she's been left only with a small amount of epilepsy. This woman suffered from her medical specialist not letting her know what the risks of her medication to her pregnancy were. And just think of the number of occasions and opportunities that were missed with her GP and specialist appointments when they could have told her that sodium valproate was not the optimal drug to take during pregnancy. This young woman here was being transferred for ECMO due to a life-threatening asthma attack. Nobody examined her properly, and so the mass arising from the pelvis was only discovered by the CT scan used to establish the safe placement of her ECMO lines. Now, in this case, the pregnancy was a little irrelevant because she's so critically unwell, but the problem was that nobody looked. I spend an awful lot of my time liaising with doctors and radiologists or radiographers to ensure safe imaging occurs without terrifying the woman in the process. I've heard of women that force the women to sign consent forms for x-rays and CT scans during pregnancy, and our radiographers often send women back after changing their minds with the simple phrase, "Are you sure it's safe in your condition?" We see women with lung cancers who present with advanced disease after being denied basic scans, and we expose women to far higher radiation scans that they need when they haven't even had a basic chest x-ray. So how are you going to be able to fight your woman's corner? You need to be educated, and you need to be able to educate that woman so that she can go to radiology confident of her low risk. Most of the scans that we do are very low radiation. 10 days living in London or one transatlantic flight is roughly the same amount of radiation as a simple x-ray. The baby's actually very well protected inside the body, and it takes a large amount of radiation to damage it. We think about 200 milligrays is the threshold level to cause enough damage to either cause a miscarriage early in pregnancy or increase the risk of childhood cancer thereafter. Our information is, however, very scanty, and it's based around catastrophes such as Hiroshima and Chernobyl. But let's face it, nobody's going to get ethical approval for a randomized controlled trial. So here you can see the data on exposure at various gestations and what the threshold levels of radiation that need to cause damage are. Just note that in early pregnancy, up to about 4 weeks, there is an all or nothing rule where sufficient damage will actually lead to a miscarriage rather than the pregnancy carrying on horribly badly affected. So how much radiation do our common scans cause to the fetus? So you can see here that a chest x-ray will deliver about 1/100th to 1/10th of 1 milligray to the fetus. A CTPA will deliver between 1/10th to 100th to 1/10th of a milligray to the fetus. And a VQ scan will deliver a little bit more, but that's because the radionucleotide is excreted through the kidneys to the bladder, which of course lies next to the uterus. Now, we would of course only do the last 2 groups of scans in women if it was particularly important for the health of the woman, because in theory it might double the risk of childhood cancer. But then you can see in the legend here that the risks that they document are still very much lower than the natural risk of childhood cancer, which is 1 in 500. What was that threshold dose for damage again? Yes, it was 200 milligray. So you can see a chest x-ray that is less than 1/100th of 1 milligray is something that we should be reassuring our women about. So if we're to consent our women properly, we need to give them all of the right information. There is less risk to the fetus in terms of cancer risk from a CTPA than there is from a VQ scan, but both scans give very low levels of irradiation. There is more risk to the woman from a CTPA due to the effect on the breast and lung tissue due to the increased blood flow and increased metabolic activity of those tissues during pregnancy. CTPA is quite difficult to get right in pregnancy due to the faster blood flow, and so getting the opacity in the pulmonary arteries correct is much more difficult, and so more inadequate scans result. Overall, though, 2 scans are vastly more risky than 1, and so it's really important to choose the correct one first. You should not do a VQ scan if you've got an abnormal chest X-ray, or if PE is not the most likely diagnosis. So just a couple of notes from this list. Because the risk of radiation for normal chest X-rays is so low, lead shields offer very little extra protection, and so don't insist on the woman having them. It gives them false sense of security. Secondly, MRI is safe in pregnancy. There used to be a theoretical worry that acoustic damage could occur to the fetus due to the large banging sounds in the machine. However, this has been soundly disproved. There are some radiologists, though, that still believe this is a problem. And so it's really important to follow up your MRI request to check they haven't been put to one side until the woman is not pregnant anymore, just to be on the safe side. Breathlessness. So breathlessness is a very common referral to the acute medical take, as you can see from this audit that I did. Now, about 60% of the cases that presented to our take in UCH were due to breathlessness, and overall about 3/4 of women will present with breathlessness throughout their pregnancy. Most of the time, it's not going to be a problem. However, it could be something more sinister. It could be pneumonia, it could be worsening lung disease, it could be signs of arrhythmias or heart failure or even lung cancer. It takes a careful examination and careful history to try and get to a clue to which one of those it is. The physiological change in pregnancy, and in particular the deeper breaths, are unfamiliar and so cause worry to the woman. The 3rd trimester is often the most troublesome, though. It's not normal to have a marked increase in respiratory rate in pregnancy, however, and so, like outside of pregnancy, this should be investigated, as it can be a sign of decompensation or metabolic stress, for example, ketosis or sepsis. Clotting changes are designed to avoid bleeding to death during delivery, hence the highest risk being during the peripartum period. However, the risk of PE is raised right from the beginning of pregnancy. Despite us all worrying about it, and despite thrombosis being the 2nd biggest cause of death in pregnancy, thrombosis like this only really affects 1 in 1,000 pregnancies, and PE only affects about 25% of those. The cardiovascular system undergoes significant change in adaptation to pregnancy, including an increased heart rate and cardiac output, reduced systemic vascular resistance, increased plasma catecholamine concentrations and adrenergic receptor sensitivity, also atrial stretch and increased end diastolic volume are due to increased volume expansion, up to about 40% by the end of the 2nd trimester, as well as getting hormonal or emotional changes. And it's a combination of these and the heightened visceral awareness experienced in pregnancy may lead women to seek advice for symptoms that are within the normal range and might have otherwise been ignored. The immune system is suppressed to permit the foreign DNA that is the fetus to be tolerated. However, this in fact impacts the immunity to other things, in particular encapsulated bacteria, and then swine and normal influenza. But not, it appears, COVID in particular. It appears in early and the middle of pregnancy. It's no more likely for a woman to develop severe COVID than anybody outside of pregnancy. But we are still a bit concerned about the 3rd trimester and early postpartum period. We do know that should women catch COVID in pregnancy and develop the severe form, then they tend to decompensate very quickly. So it's very important to have a multidisciplinary approach to managing these women, utilising obstetrics, medicine, intensive care and anaesthetics, as well as the paediatric and neonatal team, in order to plan a safe delivery and transfer to the critical care environment. I think personally that once the woman hits an FiO2 of 60%, we need to really consider delivery very quickly. Think about pre-existing diseases as well, because these will also affect breathlessness within pregnancy. So asthma is usually very well tolerated in pregnancy, so long as the woman continues to take her treatments effectively. She needs to be reminded that all the treatments that we use are safe in pregnancy, including steroids and including theophylline, if, for example, she has to come in for an acute exacerbation. Please don't deny life-saving treatment to women who are pregnant, because the baby tolerates the death of the mother very badly. Women should be reminded to stop smoking. They should be reminded to have their flu jab. And we need to check their inhaler technique at every time that she comes in for pregnancy. And we need to make sure that she's got an asthma safety plan and that we know her best peak flow. This is an example that I've downloaded from BTS. So a couple of cases. This was a morbidly obese woman who presented around pregnancy and delivery. So she'd been breathless every day during her pregnancy, but there was a massive step change after she had a vaginal delivery. We took a chest x-ray, but there was no pulmonary edema. We went back over the chest x-rays and found that 6 years ago she'd had another chest x-ray and it looked exactly the same as this. Can you see the problem? Perhaps the PE that was taken for the CTPA taken for query PE will help. And you will see that pretty much all of her stomach is in her mediastinum. And she'd got essentially a huge sliding hiatus hernia and was getting reflux. And this was what was causing her problems with breathlessness lying down, which, as you'll remember, is a red flag. So she was treated with raising the head of the bed, given antacids, given prokinetics, and referred to the surgeons to see if they could fix the problem. Also remember other diaphragmatic diseases. In this case, you can see a large eventration, causing a large amount of bowel to be in the left hemithorax and causing breathlessness from that. This lady was admitted to the medical take about 4 to 5 days after being discharged from giving birth. She was hypoxic, she was lethargic, and she had a large amount of peripheral edema. On further examination of the notes, it turns out that she had had puerperal sepsis and had received 6 litres of fluid around the delivery point, and then she was discharged quite soon after that. Now, the change in vascular tone happens days 2, 3, 4 after delivery, where all the estrogens and progesterones produced by the placenta come crashing back down to normal. Your vascular tone increases, and therefore you've got all of that normal 40% extra blood volume that needs to be fitted into a much tighter space. And there simply isn't enough space for another 6 litres of fluid. And so she went into massive pulmonary edema. And as this can be confirmed on this CT scan below, she needed a week's worth of intravenous frusemide to offload her. Be aware that if you have somebody with severe preeclampsia who's in pulmonary edema, this will also look like her chest x-ray. So how do you manage pulmonary edema? Well, you need to address the cause. Now, if it's due to fluid overload, then decrease the preload with frusemide. If it's due to a high systemic vascular resistance scenario, then decrease it using vasodilators, magnesium, and so on. And remember, you can use inotropes, assist devices, and ECMO. And in fact, that's probably the right thing to do. Palpitations in general are fairly well tolerated. However, if they're left sustained for a large, long period of time, then it can predispose to a pericardium cardiomyopathy. So please do request a 24-hour tape or an echo if a woman has sustained tachycardia or if she appears to be decompensating. What would you treat it with? Well, you can treat it with any of these medications that are considered safe. Now, this list is from the recent 2020 ESC guidance on cardiac disease in pregnancy. And as you could see here, things like beta blockers are safe in pregnancy in general, And people with POTS disease particularly find propranolol very useful at even low doses of 20 to 40 milligrams up to 3 times a day. So what's the take-home message? So please watch the video that's associated with this poster on the left. In pregnancy, as with everything else, you will find the answer from taking a careful history and examination. Please always ask for help. Ask your medical reg, ask your consultant. Please ask for an obstetric review. And if you've got an obstetric physician in your hospital, then involve them too. In general, and particularly in an emergency, treat the mother as though she's not pregnant. It is safe to DC cardiovert. It is safe to have thrombolysis. And if in cardiac arrest, you will massively improve the outcome for the woman by removing the baby. Every contact counts. Please don't miss your opportunity to make sure that your women understand the risks associated with their medicines or not. Because actually not taking medicines is associated with a huge problem of morbidity and mortality. This toolkit is fantastic and was prepared by my colleagues in obstetric medicine. There's a November 2019 version. Please download it, memorize it, and use it in your day-to-day work as well as in your exams. There are also podcasts available through the RCP as well. If you would like to go on a course, there's lots of courses available. This selection are just the ones available through the Imperial College, but you will find other ones available locally. Now, there's a lot of information available on the internet on safety of drugs in pregnancy and breastfeeding if you know where to look. So the BUMPS website that you can see here is run by the UK Teratology Service that's based up in Newcastle, and it's a fantastic resource. If you can't find the answer that you want here, you can actually contact them personally by phone, and you'll find the number at the front of a paper BNF. There is also drug monographs in the tox space for safety in pregnancy. If you want information on drugs in lactation, don't guess. Please look it up. This is the website, the UKDILAS. You can see the website address there. And this is run by the UK Medicines Information Service based up in Trent region. And this is a nice searchable website. An alternative is the LactMed app. Unfortunately, if you haven't downloaded it by now, it's no longer available. Last but by no means least, you've got the Royal College of Obstetrics Gynecologists website, whose green top guidance on medical problems in pregnancy are all co-authored by physicians and are so a comprehensive and fantastic resource. And then for your revision and general information purposes, my colleague Charlotte Fries concocted this medical problems in pregnancy teaching aid that is available on the electronic library for health. So thank you for listening. Good luck in your jobs, and I'll be available for questions on the panel after the next presentation. Thank you. Goodbye.